Care of the Aging Adult, Unit 3, Part 3, Martha Olson, Iowa Lakes Community College. Continuing on looking at the assessment of the older adult, we can see that there are vision changes. We know that that cornea decreases in transparency. That causes a reduction in the amount of light entering the eye. Presbyopia is a term that we use. It's the inability to focus on nearby objects. That sensitivity to contrast, or the ability to observe a pattern in a different light and intensity, declines. So driving at night, seeing road signs can be difficult. Many of your older adults will simply drive during the day, and they will not drive at night for that reason. They are afraid of an accident or losing their license or causing problems. We look at some of the conditions for this unit: glaucoma, cataracts, macular degeneration, and diabetic neuropathy. We will be discussing those in class in a little more detail. Remember, glaucoma is that increase intraocular pressure, and usually eye drops are the treatment, and your cataract is that loss of transparency of the lens of the eye, and the typical treatment for that is surgical removal of the cataract. Sensory hearing, then, the cerumen is the other way of saying wax. We know age-related shrinkage of the cerumen glands causes earwax to become drier. In the clinic, I've removed a lot of earwax. That's really the only job I've ever had where we remove the earwax. With the ear, the external outer ear loses elasticity. That external ear canal narrows, and sometimes the tympanic membrane can stiffen. Hair on the external ear becomes stronger or longer and more dense. With the middle ear, the loss of elasticity, the ossicles or those bones tend to shrink, and there can be calcification of the joint capsule. With the inner ear, that loss of elasticity at the basilar membrane, shrinkage and loss of hair cells, and some of our smaller blood vessels in that cochlea lead to reduction in the endolymph production and decreased ability to sense the vibrations as they travel through that ear. And as we look at the vestibular system, that is dizziness from a compromise in that vestibular balance can occur more often in the elderly. When we look at our hearing loss, that presbycusis is part of that hearing loss in the elderly, decline in the threshold sensitivity, the ability to hear high frequency sounds, and the ability to discern speech. I know in the nursing home, the male aides or male people that speak lower oftentimes are heard better by the elderly as they start having some hearing loss. So as you know, female caregivers perhaps trying to lower your voice when working with the elderly might help them to be able to distinguish your voice and what you are trying to discuss with them. Hearing loss is most closely correlated with the sensory neural disruption. When we look at communication with speaking, we think of loss of teeth. Many times their voice is more raspy. With that stroke, I would study up on expressive and receptive aphasia. Expressive is the inability to make your needs or your thoughts known, and receptive is they don't understand the sensory, the communication from other people. Oftentimes they will develop alternate ways to communicate with others when one form of communication is altered. As we look at the skin, we know that chronological, the passage of time, thinness and loss of elasticity, wrinkles. Wrinkles usually start at the eyes, become around the nose, then later years around the mouth. Extrinsic is from the exposure of that skin to smoking, poor nutrition, and lots of sunlight through the years. And when we look at photoaging, it's the most visible changes in aged skin are a result of photoaging, that sagging, more of the deeper wrinkles, and it becomes leathery looking or very kind of hardened. It does weaken the body's protective barrier against the ultraviolet radiation. The melanocytes tend to increase in size and group together, and that's when we start seeing things like age spots. They are the melanocytes that have decided to join together. Flattening of the epidermal-dermal junction is lost. This allows that epidermis to be more easily separated from the underlying dermis. Where you need to know that is, you put tape on to hold your IV down when you go to take the tape off. Those two layers that have lost that junction now are more easily damaged. They're very susceptible to bruising and tearing of the skin, as well as blister formation. And the most noticeable of the integumentary changes is wrinkles. Which one is cancer? The one to the right is a melanoma, and the one to the left is more of your cherry angioma, which is a normal sign of aging, non-cancerous. In tegumentary, the dermis has that decline in the vascularity. What we see is loss of blood flow, and they may have more of a pale appearance to their skin. The nerve endings decline in sensations of pressure and touch, and the older person is more prone to injuries resulting from poor detection of sensory stimuli. Other parts of that integumentary system, the hair follicles may be destroyed, thinning of facial hair on men. Women tend to get more facial hair. The male eyebrows and ear hairs are longer and more coarse. Gray hair is a gradual loss of the functioning melanocytes. Many people will color gray hair, and many people in their 30s start getting gray hair. As far as fingernails, they become thinner, drier, and more brittle, and they oftentimes will change shape, becoming maybe more concave or flat. And the glands decrease. Sweat glands lead to some problems with thermoregulation and difficulty with staying cool, so they're at higher risk for heat stroke as a result of some of the changes to the integumentary system. The size of the sebaceous glands decrease, so that we see rougher, drier skin. Many of your older adults will not bathe as often because of changes to the integumentary. They don't think that they have an odor because they don't sweat as much anymore, and that sometimes can be an issue for them. When we look at immunosenescence, it's the aging of the immune system. There is a decreased incidence of infectious diseases such as bronchitis and influenza. Increased incidence of diseases such as bronchitis, influenza, tumors, and cancer. And when we look at the next one down, replicative senescence, that's where cells have just a finite number of replications or divisions, and that can result with getting older. They exhaust their ability to divide. So these cells have worn out. They don't have the ability to divide anymore, and that's particularly true of some of the immune cells that repeatedly encounter antigens, thus leaving your older person more susceptible to catching some of the things that are out there. They respond less efficiently to new antigens that threaten their own body, and they're more vulnerable to disease and infection. They also have a diminished febrile response to infection. So when I have an illness, I'll run a fever. When your older person has an underlying infection like pneumonia, urinary tract infection, cellulitis, sometimes they are not able to exhibit that the same as a younger person, and usually confusion or change in cognition, they become irritable, are the symptoms that they demonstrate or exhibit for us to pick up on and be able to get them in for treatment. As far as the hematopoietic system, we know things like anemia and hemorrhage can be seen. When we look at blood cells, we know that the stem cells from continual shortening of the telomeres can cause some changes in the ability of the blood cells to reproduce, and the reduced capacity to produce some of those then can cause some changes in our ability to blood clot and make new red blood cells. When we look at some of the assessments that we do, we have to remember that comprehensive assessment for them, information, what tools are we using, what is our nursing skill level, working with the older adults to help individualize their plan of care. We collect both subjective and objective data from them to help write our nursing diagnosis and to be able to interpret what we are seeing with that older adult. And then when we think interpretation is an art, and it's an art that nurses must aspire to master both as students and practitioners. It's important that we have good assessment skills because we may be the only nurse in the long-term care, maybe in a home care situation that is looking at that older adult, and without sharp assessment skills, we will miss important things that need to be dealt with or looked at. When we look at functional assessment, our ADLs, IADLs, and AADLs are important classifications when we try to help know what we can do, how we can approach different subjects to help the elderly. Ask questions about their ability, don't assume, and then observe and look at what they're able to complete and do independently as we are writing our nursing diagnosis to know, are they safe to live at home? Would assisted living be better? Because many times it's the nurse that looks at many of those functional abilities. ADLs are things like ability to get dressed and eat. IADLs are interacting with the environment, like being able to shop, use the phone to call 911 if they needed help. And then the AADL is looking at many of their hobbies or recreational activities, and they're all important in seeing the whole picture for that older person. How we assess that functional then is their ability, appropriate nursing interventions to support maximization of what they can do. So if they are still able to cook but they can't clean, do we need to get somebody in to help them do that? We don't want to create an excess disability where it's not appropriate, because we want them to feel and maintain as much of their independence as they are able to manage, to help decrease depression and also making them dependent on us when they don't need it. When we look at that physical assessment, sexual function, it might be more appropriate to say, tell me about your sex life versus do you have sex? Sexual relationships are very important to many of our older people. It's not just something for the young. And as we conduct an assessment, we also need to include this as part of what we are asking. Explore the implications and meaning of that physical health changes for them. And there are two myths about sexual function that do exist regarding the elderly. Older adults are not interested in sex and not sexually active. Those are not true. There are some factors the book talks about related to this, such as medications, being widowed, maybe having a chronic illness that this part of the life for them has not been able to happen because, you know, they have oxygen, they have a colostomy, they have COPD, they've had a total knee replacement. STDs and HIV/AIDS are still a consideration, though, as we look at our older adult, and we can't ever rule it out that, oh, they're 80 years old, they can't have an STD, but they could. When we look at our cognitive assessment, you know, there's a lot of things. It's very difficult to separate one from some of the other comorbidities, such as physical or psychological conditions, side effects of medication. Usually it's a gradual and modest decline in short-term memory, and we use a lot of our reorientation measures with them to help them maintain. The mini mental status exam is one of those assessment tools that we use as we look at the cognition for the older adult. Our psychological assessment is looking at quality of life, what is successful aging, what is important to them, and then assessing that quality of life. What is successful aging to each person? It's very individualized. Maybe it's physical health, it may be being independent, living alone at home, their ability to function independently, longevity, maybe having a very active social life, attaining some of the goals, or just a few of the things that we can talk about and think about with the older adult. We will wrap up with Unit 4 here in the last one.